So I'm really excited to be here to do this again with you guys. Karibuni, all of you from everywhere you're tuning in from. I hope everybody is safe, warm, and home. Yes. So today, yes, we're going to talk about headaches. We're going to focus more on the danger signs and symptoms. What do you worry about? What do we not worry about? And like I usually like to do, I like keeping it as simple as possible. Feel free to chime in the chats in the Q&A, ask your questions, give your contributions. If I ask a question, please answer, please engage, talk to me. Yeah, and let's have some fun tonight. Okay, so I'm sure everybody has heard of a headache and has had a headache before. Some fun etymology is the origin of words. So yes, head pain in your head. Like Dr. Nyashio said, it's a very common complaint that patients come with to the ED, saying, oh, Daktari, I have a headache, or even you might find your family, your friends, your relatives saying that, oh, they have a headache. Can you help them? What's happening? Things like that, okay? So yeah, very, very common thing, high yield, that we always encounter. And like I said, the goal is just to identify the high-risk headaches. We're going to focus more on the questions that you need to ask when you're seeing a patient who says they have a headache, so that you can carefully send them home, or the ones that you're like, no, I might need to keep you, and the ones that you're like, okay, maybe I can discharge you, but with a follow-up plan where you come back in a few days, having done some investigations of some sort. Yeah. Okay. Headaches can be described or categorized in two ways. We can have, I'm sure everybody knows the different kinds of headaches, but an easy way, especially for emergency care providers to think about them, is primary versus secondary headaches. So primary headaches are the ones that are just in the head, no fuss, no muss. When you give them painkillers, it goes away. But then now secondary headaches are the ones that are the meat of this talk. These are the ones that have an underlying or organic cause that you have to identify, because the underlying cause could either kill your patient or leave your patient with long-term morbidities that if you picked it up first, you can reverse, okay? So what this means is like, yeah, so primary headaches, just in the head, something's happening in the head, and it's a short-lived thing, and if you treat whatever that is, it goes away. Secondary headaches can be caused by something else going on in the body, so can be high blood pressure, can be your neck pain, can be traumatic, can be bleeds, can be poisoning, can be dehydration. So once you identify that, whatever is causing it, you treat that cause and the headache goes away. Okay. So like I said, primary headaches, most of them are divided into three. Some international coalition of headache experts add a fourth and a fifth one, but these are the main types of primary headaches. So we have the migraine headache, which your patient is more likely to be like, oh, I have a headache on one side of my head, it's throbbing, or like a really harsh hammer to the head. Can start really slow and then progress over a couple of days. They might have nausea, a bit of vomiting, plus or minus auras, like visual auras and things like that, often with young people. And then like movement and exercise can make it worse. So these are the ones who want to stay in dark rooms, quiet. Yeah, so painkillers, different kinds of painkillers used to treat migraines. But it's very easy, given that it often can recur, it's very easy for people to become dependent and misuse medications, especially because of the regularity. Then there are tension headaches where you feel like a band around the head. Often, once in a while, episodic. Some people who have common triggers can have them more commonly, usually older population, 30 to 40 years. And they don't have anything like photophobia, nausea, vomiting like the migraine headache. So it's just a tension headache that needs some painkillers, and yeah, they're fine. Then there's a cluster headache, similar to migraine. Main difference is that they're usually very, like migraines, they're unilateral, yes, but they can be stabbing and piercing in nature. They can last for a long time without remission. And you'll see these are the patients who come in with tears, tearing, crying, and things like that. Yeah. So these are primary headaches, which analgesia, rest, hydration, those kinds of things tend to treat them well enough. They go away. These are not the focus of our talk, but it's good to know that those are the primary headaches, that if your patient comes with these kinds of symptoms, you're thinking it's a migraine, you're thinking it's a tension headache, you're thinking it's a cluster headache. You're not thinking that something more sinister is going on. Okay. So these often don't require additional testing. So you just give your patient painkillers, they go home, they're fine. If it's like the migraines, there's a way to approach migraines, which I won't delve into because I'm not a neurologist. Yeah, there's a way to treat them, but usually they don't require additional testing or evaluation, especially in the emergency department. These are people who you can safely discharge. If it's a migraine headache that needs follow-up later on, you discharge them through the relevant clinics or follow-up. Yeah. Okay. Now, secondary headaches, like I said, these are the ones that are being caused by something that originates away from the head. These are often very suspicious because, like I said, it could be the underlying condition causing it could be something that could kill them, could be something that could cause long-term detriment to your patient's health and functionality. So these must be evaluated, like must be evaluated. And there are different ways of evaluating secondary headaches, and it all depends on what you're thinking it could be. Yeah. So you want to target your investigation based on your history and physical exam when that helps you lead to your possible diagnosis. Yeah. So this is the meat, this is the main focus. These are the ones that as an emergency practitioner, emergency caregiver, these are the ones that you need to be able to tease out and pick out from any other headaches so that you know who is high risk, who could die. Because like, if you remember in the How to Think Like an EM Physician talk, we said you have to always assume the worst, rule out the worst first before you try and think about the less serious causes. Okay. So, so like I said, they can be killer headaches. I'm sure we've all, feel free, all 237 of us in the in the webinar, feel free to chat, to write in the chat, like what some of the causes of killer secondary headaches could be. What do we think is a headache that can kill you? Is it somebody who has had a headache for 5 days and has a flu? Is it, what are some examples of killer headaches that we know of? Please feel free to type in the chat. Okay, Thomas Mashuma says hypertension, traumatic brain injury. Faith says headache post-trauma, trauma, subarachnoid, yep. Stroke, yep. Yeah, so that's very correct. Space-occupying lesions, yep. That's absolutely correct, guys. So those are the ones that we're thinking about in our killer headaches. So you're thinking bleeds, whether they're traumatic or non-traumatic. So the traumatic brain injuries, the epidural, subdurals. More often than not, it'll be actually, yeah, epidural, subdurals, and then the non-traumatic ones, whether it's a subarachnoid, ruptured aneurysm type things. Then you're thinking about your clots and not just your strokes. You're also thinking about your venous sinus thrombosis. Yeah, so those people will can come to you, and the only complaint is that I have a really, really severe headache and it's not going away. Then we think about infections like meningitis. That is a big killer. So you should always have a very high index of suspicion for meningitis. Then also never forget the pregnant patients, preeclampsia with severe features nowadays, the uncontrollable headaches, like you take painkillers and it's not going away. those are killer headaches that you need to start thinking about. Okay, great. So for these headaches, how do we approach it? So we have a bit of an algorithm for killer headaches that you need to rule out, yeah? So like we said, the most important thing you need to start with is history and physical exam, yeah? History, number one, is gonna be your main thing. Sometimes, of course, if your patient is in severe pain and they're alone, you might not be able to elucidate that much of a history. And as emergency practitioners, we make decisions with very little information a lot of the time. So number one, if it's somebody who walked into the hospital, you want to at least try and give them a trial analgesia, right? So you want to give them a trial of analgesia and see if that makes them a bit more settled, and then they can give you the history, right? Because you don't want your patient to just suffer so that you can tweeze out history. It doesn't make sense. And then also even the people who brought them, whether it's a relative or a Good Samaritan or whatever, especially in cases of like accidents where somebody is brought in by a Good Samaritan who only knows that they were in an accident, or they pick them up on the side of the road. So you need to be very cognizant of those kinds of situations. And you need to be able to ask very pertinent questions, give some analgesia first. Yeah. So some of the targeted questions depends on what you're thinking could be happening. Yeah. So if it's a hemorrhage, there's some subarachnoid hemorrhage, there's some questions that you need to ask. Like, when did the headache start? If somebody has a headache for like 5 days, you're thinking, okay, maybe it could be something else. If they say that, yeah, I've had a headache and it got really severe really fast, like within the first minute to an hour, it got to like maximum severity. It's something that they've never had before. It's the worst headache they've ever experienced in their lives. They had nausea, they vomited, or they lost consciousness. How is their vision? Are they seeing double? Can they see you clearly? Are they sensitive to the light? And then in terms of, so those are some of the questions that you start off with, right? Tell me about your headache. What does it feel like? Some people will be like, oh, throbbing, or like it's really, some people won't even be able to describe in terms of like the textbook where we've learned. They'll just be telling you it's really, really severe, it's really, really severe. So you want to know, how did it start? Yeah, the onset of a headache is very, very important, because some of them will start and some of them will start and they don't think it's anything really severe, and then they come to the hospital 5 days later, as opposed to those ones that have started and cannot be ignored. Something that starts and reaches severity very fast and can't be ignored by the patient or you has to be taken seriously, okay? So yeah, so if your patient has a thunderclap headache, the one that's maximum severity in a short period of time, is unlike anything they've ever felt, is the most severe in their life, and they've had one episode of fainting spell, your index of suspicion for a subarachnoid is very, very high. And that also tends to now my next slide. There's actually a clinical rule or guideline that you can use to elucidate some of the symptoms when you're thinking it might be a subarachnoid hemorrhage. So it's called the Ottawa Subarachnoid Hemorrhage Rule. It's best suited for patients who are above 15 years who come with a non-traumatic headache. So remember, they can be traumatic or non-traumatic. So these have to be non-traumatic, which reaches maximum intensity within 1 hour. So these are the ones who come hunched over saying, oh, my head, and it just started like a few minutes ago. This rule can't be used in patients who've had like chronic headaches or similar headaches in the past couple of months. They can't be used in patients who have neurological deficits, previous aneurysms, or previous tumors, because it kind of becomes less sensitive to pick up the patients with an active bleed. So when you're thinking about, remember Socrates, right? Sight, if it's like at the back of the head associated with neck pain and stiffness, that's a very high risk headache. If the patient is more than 40 years old, they did have an episode of syncope that was witnessed. So there's a difference between witnessed syncope and perceived syncope. So some people will say, oh, I blacked out, when in actuality, the pain was just so severe that they can't process any more information, but they didn't actually lose consciousness. So that's why it has to be a witnessed loss of consciousness. Another high risk thing that you have to ask, did it start when they were exerting themselves? Like they were exercising or doing a Valsalva maneuver or things like that. Then, like we said, the thunderclap headache, where it reaches peak intensity immediately. And then when you're examining them and you ask them to like move their neck down side to side, they have pain on those movements and limited flexion. If any of these, even one is present, you cannot safely rule out a subarachnoid. So that means that you have to evaluate them further. So how do we evaluate further? You must, when you're looking for, so subarachnoid is a bleed, right? When you're looking for a bleed, you do a CT scan. No questions about it. Bleed, CT scan. It's fastest, most sensitive, easiest to do. Yeah. But also there's a caveat for when the bleed happened. But yeah, again, that's more academic. But yes, so if any of these are present, you need to scan them. The only other thing that I'll add as a caveat in number 6, if it's a patient who previously had like migraines and stuff, you want to know, is this headache similar to your migraine headaches? Yeah. Because if it's similar, then it's definitely not a SAH. But if it's really, really severe and different from the usual headaches, you're thinking it could still be a subarachnoid. Okay. I hope everybody's still with me right now. Yep, good. Okay. So that's for subarachnoid. Then you'll do the physical exam, like we said, the signs of meningism. Then your action point will be to do a CT scan. And then LP has some utility, especially when it comes to time duration, because you will get red blood cells in the CSF fluid called xanthochromia. Yeah, so these are patients who definitely you'll need to admit under a neurosurgery consult, whether you have it there or refer to where there's a neurosurgeon who can take care of them. Yeah, and there's a medicine to help reduce vasospasms, nimodipine. If you have it available, you need to give it. If you don't, again, refer. So that's subarachnoid. Now when it comes to meningitis, again, still history. History is your biggest tool. You're thinking about your patients who have fevers, neck stiffness, photophobia, plus or minus history of like immunocompromised state, which could be known to them or unknown to them. If it's known to them, you have to ask directly, and in more than one way, because I'm sure we've all gotten patients who in the first instance, when you ask them, oh, do you have any chronic illnesses? They say no. Then you ask them, okay, are you on any medication? Have you been taking any medication for a while? They're like, oh yeah, by the way, I usually take dawaya this, dawaya that. So could be an English problem, could be a acceptance problem, but you have to ask the question in more than one way. And then when it comes to sensitive matters like HIV, you want to do it in an environment where the patient feels safe. So by themselves, so that, especially because you don't know what level of disclosure they've achieved with their people. So you want it to be a safe environment where you've established trust and safety for them, excuse me, so they're able to actually open up to you. So that's for the ones who are known. For the ones who are unknown, you want to look for markers that are suggestive. So in terms of like your physical exam, if they look like they have oral thrush, they have Kaposi's, wasting, things like that, you want to know if you can also further test for that. So those are some of the flags that go on in your head. Like your mind is just working at like 300 kph because you don't want to miss something that could kill this person. So yeah, so you're thinking about your constitutional symptoms and you're thinking about your whether your patient is immunocompromised or not. Okay, then you do your physical exam, look for any signs of meningism. So like your neck stiffness, and neck stiffness is both active and passive, right? Active is them doing it. And then passive is you doing it to see if you can feel any neck stiffness, right? And then there's the Kernig's and Brudzinski. If you can do them correctly, do them, and do them the right way. And then also even subtle signs like the patient only wants to be in a dark room, things like that, you need to also take into account. Okay, so patients with meningitis. Do you need a CT scan to diagnose a meningitis? To diagnose meningitis in a patient? So what do you guys think? Do you need a CT scan? Okay, Thomas says no. Yeah. So yeah, meningitis actually is a clinical diagnosis. If you suspect it, you should actually tend towards treatment more than anything. And even there's a rule that if you suspect a patient has meningitis, they fit the criteria, you need to start antibiotics as soon as possible, even without like cultures and things like that. These are patients who, yes, you don't need a CT scan, but if you can do it, please do it. If you can do a fundoscopy, check for any signs of papillary edema, do that as well as part of your clinical exam. Then you want to do your lumbar puncture and then start your antibiotics, right? And yeah, do your HIV tests at your own discretion as needed. Yep. So that's meningitis. Then, like I had mentioned, so you could have a clot somewhere, right? And the clot could be inside the large vessels of the brain, the arteries, or it could be in the venous system. So the ones in the arteries, yes, is the strokes. So if your patient has a large stroke where you do your clinical assessment, you do your NIHSS, and it's a large territory one where in terms of the NIHSS, it's more than 16, you're thinking that's quite a big one, and there are usually other secondary effects that could happen. They will present with a headache, they will have the neurological deficits, and when you scan them, they can also have cerebral edema and things like that, that make it very dangerous, as opposed to somebody who's had a minor stroke where the NIHSS is like 4 or 3. But again, you'd still need to investigate for that. So depending on the time that they come in, you want to do either your CT scan or your MRI, right? Yeah. Then now for the clots in the venous system, right? You're thinking, so your patient, I don't know how many people have met patients who have central venous sinus thrombosis or venous sinus thrombosis, the CVSTs, where there's a clot in like their, anybody? Okay, all right. Okay, so these are the patients who come with like really severe headaches. They'll probably have a seizure, and then they'll also have weakness. Yeah, but the weakness often will not be like, you might be tempted to think it's a stroke, but there will be some things that are a bit off about it that confuse you and make you think, okay, maybe it's not just a stroke. So what I mean by that is this is a patient who come with like a multi-territory weakness. Like they'll have both upper limbs are weak or both lower limbs are weak. And we know that with strokes, it's usually like one-sided and things like that, unless you have like multiple clots. So yeah, headache, weird seizures that are not typical seizures or new onset seizures, and then stroke-like symptoms or neurological deficits that don't that cross territories, basically. Yeah, you know how you have your ACA, MCA, PCA territories. So for a CVST or a venous sinus thrombosis patient, they'll have neurological deficits that cross more than one region. So that's one of the ways, one of the giveaways for that. Yeah. And then so in terms of your clinical exam, for, like I said, there's the NIHSS scale where you score the neurological deficits from how they're talking to you, the strength in their upper lower limbs, the facial deviation, If they have any sensory deficits, you want to do that and scale your patient. And then you also want to do a fundoscopy where available to check for any signs of cerebral edema. Like I said, the largest strokes can give you cerebral edema, increased cerebral edema, which will also manifest with some papillary edema. And then even clinically, those are patients who at minute 0 when they come into you versus like an hour later, you'll notice that their GCS seems to be declining a little bit. Yeah, so these are patients you want to scan, and you have to pick the appropriate scan depending on what you're thinking. If you're thinking it's a stroke, whether it's a new stroke, within like 4 hours, and you're thinking of reperfusion therapies, you want to do a CT scan. If it's an older stroke outside those windows, you want to do an MRI, right? If you're thinking it's a venous sinus thrombosis, you have to include a venogram in your investigation, right? So if it's a CT of your head, you want to do CT plus venogram, although the best would be an MRI plus venogram because there are a lot less artifacts. So yeah, just remember that depending on what you're thinking or what you're looking for, the investigations are an adjunct to your clinical assessment and they're not the savior, okay? Then as appropriate, depending on what you find, call the relevant teams that are going to deal with it in terms of final care and all that, yeah, okay? So these are the ones that are gonna kill you. There's also the preeclampsia headaches, like I said. These are women who, yes, you're pregnant. How many weeks pregnant are you? More than 20 weeks. When did the headache start? If it's somebody who's been having chronic headaches, what you will ask is this different from your usual headaches? Have you taken any painkillers? Is the headache going away or not? How many painkillers have you taken? Is the headache still there? Especially for those who have taken multiple types of painkillers and it's still not going away. And then in terms of your clinical exam, you want to look for your lower limb edema. You want to look for your high blood pressure. You want to check for papillary edema, things like that, and your labs as well. Yeah. Yeah, these ones you don't have to scan. So yeah, that's for the killer headaches. Yeah, so bleeds, clots, infections, and pregnant women. Okay. So we talked about when to suspect a subarachnoid. Oh, fun fact, another question that you should ask, depending on your population, is if they've taken any drugs for subarachnoids, because there's been a correlation between cocaine use and development of subarachnoid hemorrhages. Okay. So now that we've asked the questions, all these relevant questions, and we've ruled out the things that could kill you, now we need to ask more questions so that we can find out if, yes, you're not dying. We've told you, okay, you're not dying right now. So awesome. But could you still be quite sick with something that could cause long-term harm? Okay. So those are the ones that we call the MAMAs, yeah? So these are the ones that, like we had mentioned before, things that have been brewing for a while, things like SOL, space-occupying lesions. So if somebody has a brain tumor, it didn't start today, right? They might present today or in a few days. Usually it's slow and insidious. So you're asking your patient, when did your headache start? They'll be like, oh, I've had this headache for a couple of weeks. It's not going away. Initially, I take a Panadol and I'm fine, but right now, I have to really take them more regularly or top up with more painkillers, top up with stronger painkillers. There's that it's progressive, getting worse. Then when do you have the headache? They're like, oh my gosh, my headache is a lot worse in the morning when I wake up as opposed to at the end of the day. Or they can even be brought to you with a new onset convulsions. Yeah. If you check on the Casualty app or algorithms for seizures, new onset seizures, imaging is a very important part, especially to fully work up your patient, because they could have a seizure just because there's a mass growing and has triggered the convulsion. So yeah, also, of course, we're thinking about the infections as well, right? Like the tuberculomas or the brain abscesses. So you also want to know, is my patient immunocompromised or not? What is the HIV status? Things like that. So, yep. And then once you've taken the history in terms of those questions, you also want to do a proper physical exam. The slide says full neurological exam. I know sometimes it can be a bit daunting to do a full neurological exam because it starts from your cranial nerves all the way to the reflexes and sensation. But if it is a patient who you're actually suspecting that there's something going on in that head and like all your alarm bells in your head are going woof, 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 you should really do your neurological assessment, because also sometimes if they come with, I don't know, some if they come with like, if they have a cerebellar mass, you want to do a cerebellar exam, right? You want to do your nystagmus, your dysdiadochokinesias, your ataxias, even your staccato, your speech. You want them to talk to you so that you can see if they have a staccato speech or not. So it's very important to target your investigation to what you're looking for. And I mean clinical examination rather. Then if and where available, you want to look in the eyes, check for any papilla edema, see what's going on in the eyes. The eyes are the windows to the brain. Yeah. So these people, more often than not, like I said, it's something that's been going on for a while. So you might want to do you have to investigate them, yes. And in terms of your investigation, you want to do both laboratory and imaging. And in terms of your imaging, choosing the appropriate modality is what is going to make or break your diagnosis, yeah? So you'll want to do, most of them you'll want to start with a CT. Some you might want to do an MRI. Some you might also do an EEG for new onset seizures, and it's up to your discretion. Others you want to add contrast, especially if it's a space occupying lesion. You can ask for a CT head with contrast, because the contrast, some lesions take up the contrast and just glow on the scans, and that helps narrow down your differentials. So again, like I said, just depends on what you're looking for. If you really, really have a high index of suspicion that maybe it's like, maybe your patient profile is a 20-year-old male, no discrimination here, it's just a clinical scenario. So 20-year-old male who lives, let's say maybe in Mombasa side, Mtwapa, is an IV drug user, has come in with headaches for like 2 months, also has a new onset convulsion, also has weight loss, night sweats, yeah, weight loss, things like that. You're thinking, okay, yeah, you're definitely immunocompromised. You could have a tuberculoma, so you want to maybe do a CT with contrast. So again, it's just, you just need to preempt. In terms of your questions, you need to get enough answers to tell you what investigations to do. Yeah. Okay. Then there's something called IIH, idiopathic intracranial hypertension. So these are patients who also have a very, more often than not, they have a very specific patient profile. So these are more often than not women who are obese, who come in with severe headaches that are persistent to the point that depending on when they present later on, they start getting blurry vision. So if you start seeing that kind of profile, so new onset headaches in an obese woman who is now also developing blurry vision, you're thinking IIH. So you want to do your fundoscopy or get your ophthalmologist or to do a fundoscopy, look for papilloedema, because that also bolsters your suspicion that it could be IIH. Then you also want to, so these are patients who, yes, you want to scan them. And then you want to do an LP. LP is both diagnostic and therapeutic for them. So diagnostic in such that the opening pressures are quite high, tend to be above 20, so between 20 and 40. And then after you've done the LP, you've relieved a lot of their pressure. So the headache comes down, the vision starts getting better. Management has those other medications. We're not going to go into that. But yeah, so you just need to be able to say, okay, if you see more often than not, if you see an obese female coming in with headaches, blurry vision, your alarm bells are ringing. You're thinking it could be IIH if they're not pregnant, yeah? You want to look into their eyes and you want to CT scan them and give them an LP. And then the rest will be done after that, okay? Temporal arteritis. So these are usually elderly male where they come with like pain on the side of the head, worse, especially when they chew. That's what's called like the jaw claudication. They can also have blurry vision. When you touch the side of the head, it's very tender. So these patients will have like really severe long-term headaches. These, yeah, best managed by neurology. The only investigation that they really need is an ESR. These you don't have to scan the head because you wouldn't really see anything because it's a type of vasculitis basically. Yes, acute glaucoma. This is a big MAMA because if you don't sort it, you could leave your patient with permanent visual, what they could end up getting blind basically. So these patients usually come in with sudden onset, really, really severe eye pain, blurry vision. Then they also have a bit of like the pain side of the eye, also to the head, blurry vision, nausea, vomiting. And even when you look at their eyes, you might see some redness, which is a conjunctival hyperemia or conjunctivitis. These you definitely need to call your ophthalmologist as soon as possible, especially when you're suspecting that it's an acute glaucoma. The pupil can be mildly dilated, especially compared to the other one. And when you try to shine a light on it, it can be non-reactive or very, very slowly compared to the other one. So yep, ophthalmologist needs to get involved because you don't want your patient to go blind. So like I said, not every patients will come to the ED just as they are because they know you're going to sort them out with all their problems. They'll have jaw pain, eye pain, everything. So it's up to you to sort of triage them really quickly and see if your patient needs to be seen immediately or they can come to the clinic tomorrow or the day after that. Yeah. So if somebody who comes with severe acute eye pain with blurry vision, and then when you look at the pupil, it looks like that, you want them to get an urgent ophthalmo consult. Yep. Okay. Then the things like cervical dissection. So you would think that they're having a stroke, because sometimes they can even have a bit of weakness, especially on that side. Usually it's an acute severe headache. They have some neck pain or facial pain, or may have had some trauma to the neck or some sudden neck movements. Like maybe they were punched in the face and they twisted their head, or they were, I don't know, swimming or something like that. So you need to think about these patients. These are the ones that when you're imaging them, you need to do a CT angio, so that you can actually see the vessels and see where the dissection might be. And with the dissection, of course, they can end up throwing minor clots to their brain and yeah, present with stroke-like symptoms. Then, of course, if it's a patient that you're thinking has carbon monoxide poisoning, they've been in a burning house or they were tear gassed. So they have a really severe headache, they've been vomiting and nauseous, or if they're in an enclosed, especially right now it's quite cold, yeah, they're in an enclosed space, walilala na jiko kwa nyumba. maybe the door was slightly, or the window slightly ajar, but the next day they have a really, really, really severe headache until they vomit. You want to be thinking, okay, might be carbon monoxide poisoning. So these you have to, again, your history is just your cornerstone, number one. Number two, in terms of your investigations, you look at their mucous membranes, they tend to be more red than usual, but I think that's, I don't know how practical that is for us African population. So I'll just leave that at that. But if you're in a center where you're lucky enough to have a blood gas machine that can give you carbon monoxide levels, you can also do that. Treatment, of course, is oxygen therapy. So like I said, these are your patients who, so the killer headaches were your red patients, right? The ones who could die just now. These are your yellow patients who are sick and could deteriorate into red if you don't find out what's happening and intervene appropriately. Yeah. So if you remember in terms of like triage, we had the red, the orange or yellow and green. Yeah. Okay. So there's that. Then we go to your other ones. So another thing that I would like to mention in terms of your MEMA headaches, which could be yellow, also your patients who present with headaches surrounding high blood pressure. I think there's been a prompted question here from Philister, relationship between headache and high blood pressure. So yeah, you could get a patient who is a known hypertensive, who hasn't been taking their meds, and then they come with really severe headaches. A lot of the times can be a bit of an occipital headache. Again, same things happen. When did the headache start? How bad is it? What conditions do you have? Have you been taking your medication? Things like that. How severe is it? You want to also do your physical exam, which includes taking your vital signs. If it's really, really severe, you also want to screen for any signs of a bleed, right? So really severe headaches, gait ataxia. So your hypertensive emergencies, basically vomiting, nausea, blurry vision, things like that, in terms of your clinical signs and symptoms. Then please also, for these patients, for your yellow patients, make them walk. Make your patients stand up from their exam bed or their exam couch or their chair and walk. Tell them to walk in a straight line for at least a few meters and analyze that and see, are they okay? Or is their gait, affected? Are they having ataxia or not, right? Because if you're seeing a patient who has BPs of 200 systolic and they're walking in a very abnormal, they're yumba back and forth, you're thinking that they could also have a bleed, right? So these are patients who, yes, you need to scan them. So like I said, when you look for a bleed, you do a CT scan. So after your CT scan, then you also want to do your other labs for the organs. You want to see if there's any other end organ damage. So your ECG, your UECs, and the likes. Okay, great. So we've done our red, which are the killer headaches. We've done our yellow, which are the MEMA headaches that you need to address before they get to killer headache status, right? Then we go on to the other kinds of headaches. So these are the ones that if you've asked all those questions that I've just been talking about for the last hour or so, and the answer is no, 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 you're starting to sigh a little bit because you've ruled out the really scary things. Yeah. So the other things now, the urgent headaches, and then now the primary headaches, like the ones we had talked about, the three we had talked about. So urgent headaches, these are the patients who you can figure out, like if they had like a really bad flu and now they have an acute sinus headache, they're like, oh, front of my head, my nose is blocked, things like that. You're thinking, yes, it's a sinusitis headache, treat as appropriate. Post-traumatic headaches that are not severe and don't qualify for CT scan. So these patients, you have to do your Canadian head CT scoring to see if they're eligible for a CT scan. If they don't require to be there, it's just a small blow to the head, analgesia, give them danger signs, safety net everybody. So like urgent, yes, all our urgent patients, they need safety netting. Safety netting is just talking to your patients, telling them how they are likely to proceed in terms of their progress rather, in terms of their illness, and telling them any danger signs that they can expect to have. And those are the ones that they should come to hospital immediately they happen. Yeah. So that's what safety netting is, making sure. Because sometimes you get a patient who's at the start of their illness and there's really not much to do. But you tell them, okay, this could happen, ABCD could happen. If this does happen, come back immediately. So that's how you safety net your patients. And a lot of your urgent and primary headaches are the ones that you have to safety net, because it's very unlikely that you'll admit them. A lot of them tend to be discharged home and safely. But yeah, you safety net just in case something changes. So yeah, like the flus, the fever-related ones, like if they have like malaria, I mean, if they've gotten a small blow to the head, if they haven't eaten, or if it's like they've started a new medication that causes headaches. Yeah, those are the ones that you safety net, and they're the ones that fall under urgent. Yep. Okay. We see if there are any questions so far. Any questions so far, guys? Feel free to throw it in the chat.
I could see a couple of questions here. You talked about meningitis. Somebody anonymous wants to know if dexamethasone is indicated in meningitis treatment currently.
So that we'll just talk about a bit later. That's not the aim of the talk. We're not treating meningitis. We're just talking about how to identify danger signs with headaches. Okay. If you want to learn about you can read about meningitis, no problem. But I need you to be able to diagnose it from the signs and symptoms. So if you've gotten to that point, excellent. The rest will refer. Okay. So yeah. There's that. Okay. All right. Great. So let's see for the next part. So I've been very verbose talking about all these things, but there's a very easy mnemonic that helps you go through it, go through with your patients to elucidate the red flags of the headache that they're telling you that they have. So there's a mnemonic called SNOOP. So each letter stands for something. So S is for systemic signs and symptoms. N is for neurological symptoms. The first O is regarding the onset, whether it's sudden onset. The second O is regarding age for like older patients and also very young patients. Then the first P is in terms of like the pattern and progression of the headache. Then the other P is for precipitants, and if it's worse, with positional change. Okay, so let's talk about it a bit more. So systemic signs and symptoms. So these are as well as like systemic disorders. So you're thinking, like we'd mentioned, does my patient have fever, chills, weight loss? Does my patient have blurry vision? Does my patient have an underlying malignancy or an underlying immunocompromising disorder? Yeah, so that's where those questions come in. That's where you start, where the S comes in. And you can even use it to chart down the questions that you've asked. So yeah, systemic signs, symptoms, and disorders, you have to rule those out. If any one of them is flagged, you want to ask further questions because you want to know if you need to scan your patient, whether it's a red patient, whether it's a yellow patient, or whether it's a green patient. Okay. Then neurological symptoms. So this is where you want to know, is my patient confused? Is my patient having ataxia? Is my patient having visual symptoms? Is there a new change in behavior? Is my patient having weakness on one side of the body? This is where all of this comes in. Is my patient having seizures that have just started? So you want to elucidate your neurological symptoms that are red flags. So once you elucidate one, you prod further and try and see, is it linked to a certain diagnosis? Okay, all right. Then we go to the first O with regard to the onset, like with the subarachnoid. When did it start and how did it start? Yeah. Did it start very sudden, or is it something that started progressively? This can also help with your tension headaches and your migraine headaches, right? You want to know if it's a subarachnoid or is it just a migraine, yeah? Then for the age of your patient, older patients above 60 years are more high risk, and also younger patients less than 5 years are quite high risk. You don't expect a 5-year-old or a 4-year-old to say they have a headache. That's not normal, yeah? So if you're within any of those age brackets, you want to ask more questions and prod further and see what's happening. Okay, then in terms of progressive, like I said, yeah, is the pattern, basically the patterns of it, is it slowly getting worse, suddenly got worse? Has it changed character in terms of if it's somebody who routinely, okay, not routinely, often gets headaches? So that's where the progression is what you're thinking about. If any of the questions you ask with regard to progression are yes, prod further, investigate as appropriate. And the final P, is it worse with position or exertion? There are those who say, oh, I was on the toilet sleeping very hard and then I had a really severe headache. So you're thinking, are you having a subarachnoid? Is there a ruptured aneurysm or something like that? Yeah. Or if they were, yeah, with exercise, like if they were swimming and they turned the head really fast, or boxing, yeah. So you're thinking also dissections and stuff like that. Yeah, then look in the eyes, is there papillary edema or not? So Snoop, very good way to, very quick and easy way to go through your headache history taking so that you can put them into your categories, whether it's a killer headache, urgent headache, MAMA headache, non-urgent, or primary headache. Great. Okay. So somebody had asked in the Q&A, what about kids, yeah? And how common are primary headaches in pediatric population? Should we always evaluate pediatric headaches? So just like adults, children can get headaches. There's one screaming somewhere in the background. Children can get headaches, but younger kids shouldn't. So you want to know what are some of the red flags? So even them, they have a mnemonic, just that we've added a few other things, okay? So the mnemonic is Snoopy is wet. Yeah, Snoopy is a cartoon dog, if we all know. So most of it starts the same way. S for systemic signs and symptoms. So again, now for the kids, are there any fevers? Neurological signs. So here, if it's a child who's already walking around, are they able to walk normally? There's also an aspect of, have they developed a new onset squint? So it's a baby who's been born with okay, like their eyes are perfectly fine. And then all of a sudden you start seeing a squint. That's a red flag, plus on top of a headache. So you're thinking, yeah, that one you definitely need to investigate further. Then location of the headache, is it occipital? Or is it like just a generalized headache? Occipital headaches tend to be a red flag, both in adult and pediatrics. And then you also want to know, is it occurring in a high risk group? Like, so if it's a sickler who's coming with a severe headache, you're very concerned because they could be bleeding, right? Or if it's somebody who had what's it called, hydrocephalus, and they've come with a headache, you're thinking, and they've already gotten like a decompression surgery where they have a shunt. You want to figure out, when did it start, how bad is it? You want to check the shunt if it's still patent. Yeah, there's a way you press at the back to check if it's still patent, things like that. So yeah, this is in terms of any comorbid states that make them more high risk. Then postural headaches, if it's worse when leaning forward or bending, because that tends more towards increased ICP, like the pressures are quite high, so you want to ask more questions. And then, like we said in the previous Snoop, usually under 5, but even especially if it's age younger than 2 years or 3 years, those are a bit high risk because they're not supposed to be getting headaches. So it's very peculiar if they come and tell you that they have a headache. Then if they have infective signs and symptoms, so these are the fever, squint, I've talked about that. Then if it's so severe that it wakes the child from sleep, that's a alarming sign. Early morning vomiting, again, signs of raised ICP. So we're thinking maybe a mass or something. And then, or even like the hydrocephalus related, where we have shunt blockages and failures. Then is it a thunderclap headache? Because yes, they can also get bleeds. Yep. So for pediatrics, this is what we're using. Now, once we do this Snoopy is wet, it doesn't categorically mean that you have to image them. Yeah. So for children, we tend to adopt a principle called ALARA we don't want to image children if we don't have to, because like we all know, there are increased risks of developing various kinds of cancer for people who are imaged, exposed to radiation, especially CT scans. There's even a quote from the British Medical Journal that says that young people who undergo CT scans are 24% more likely to develop cancer than those who don't. That's quite a high statistic. So kids are very prone or susceptible to getting leukemias, brain cancers, just from having been exposed to some form of radiology as early as these 5, 6, 12 years old, especially when not necessary. So once you do the Snoopy is wet, it's to tell you what could be causing it, yeah? So if you do Snoopy is wet and you're like, okay, there's definitely an infection somewhere, there's a meningitis, you don't have to image, so treat that baby. Or if it's a patient who has a shunt and you know the shunt is blocked, you might not necessarily have to image them. That's why you call in your neurosurgeons and they'd be like, okay, let's interrogate the shunt, see what's happening. Or yeah, so things like that. If you're able to identify a cause of the headache without imaging, that is what we really want. But for those that you can't avoid it, you want to use as low radiation as is needed. Yeah, okay, good. So that's for the children. Only radiate when there's no other possible way of investigating. And then this is also where like the MRIs come in. Yeah, you're better off doing an MRI which doesn't have any radiation when you need it. Yeah, if the baby actually needs an MRI, as opposed to a CT scan. Yeah. Okay. So yeah, Snoopy is wet. Okay. Yes, good. Nimefika. I have given you a lot of information, but like I'll go back to my first slide. Yeah, the point of this lecture was to identify high-risk headaches, those ones that will kill your patient, the reds, those ones that will maim your patient, and to see who you can send home safely without worrying too much about. And I hope I've been able to get that objective across. Yeah. So, yep, I'm going to leave the slides as so. Always find a way to investigate, interrogate your secondary headaches further. You can use your Snoop that can help you find a possible differential. Yeah. And then investigate as appropriate. Thank you, guys.
Thank you. Thank you, Dr. Jane. That's a very informative session. Yeah, just to add on this or to reiterate, guys, always snoop your patients. Always snoop your patients who have headaches. It doesn't matter what you think is the cause of the headaches. Additionally, it's a good idea to be an expert on history taking. Sometimes what is alarming to the patient is not what is alarming to us, right? Sometimes this patient can come in with a headache and they've had a convulsion just prior to the headache, and they don't tell you about the convulsion. We just have different ways of trying to get information from your patient. In emergency medicine, we triage and retriage, we ask and re-ask, because sometimes this information tends to come out at the third, fourth, even time of asking. So I'll just go through the chat and the Q&A panel. There is somebody anonymous asking about hyperlipidemia, hypercholesterolemia, cause severe headache. When is it LDL or HDL, total cholesterol is high, can it give you a headache?
So anything is possible, of course. But you can think of it in two ways. In terms of if they're number one, if they've started new medication, that can give them a headache, number one. Number two, if their blood is so thick and viscous to the point that it's causing pseudo-stroke-like congestion, yes, it can give you a headache.
There is also a question regarding the role of steroids in the management of subarachnoid hemorrhage. Yeah, so guys, emergency medicine, we don't manage subarachnoid hemorrhage. Okay, at least not definitively. Our job is to figure out those patients who have headache and have a subarachnoid hemorrhage, and then consult appropriately. Let that decision to start on steroids, start on nimodipine, whatever dose the neurosurgeons want, let it come from them. Okay, that's how I'll answer that.
Yep. That's a good, but yeah, just learn how to identify a patient, because that's the most important thing. Do your subarachnoid rules, ask the appropriate questions, scan and find it. Because even for these subarachnoids, you might be an aneurysm, might not. So yeah, your CT plus or minus angio is where you want to be. Yep, good.
So what if this patient who presents with a headache has taken paracetamol, mara moja, some tramadol with no response? This is what Nick Kamau is asking. Do we need to be worried? Can this be used to stratify this patient as high risk?
Oh yeah, absolutely. Yes. That's yeah. Actually, yeah, you're very right. I forgot to mention that. So if a patient who comes into the hospital, they have severe headaches, then you give them some painkiller, they're not getting better. Give them the next step in your pain ladder, not getting better. Next step, those are big red flags. Headaches that don't go away with analgesia and you have to keep adding more pain meds, that is a big red flag, and you will need to investigate further what is happening. So these are patients who need scans. Number two, additional history to see what could be causing it. Is it a subarachnoid as well? Actually, there's a patient that I had once before that didn't come with the typical thunderclap headache. They just came with pain that just wasn't going away to the point of reaching maximum analgesia. So we scanned and we found an SAH. So definitely, yes, pain that doesn't go away requires further imaging. And this is also the patients that your green patients, your urgent versus primary headaches. If they go home, try the medication you've given them and you've safety netted them and told them, if the headache does not go away with this medication, come back. Yeah, so you need to prod further. Yes.
Brian wants to know whether there is any role of opioids in managing acute headaches. Which one, Brian? What sort of acute headache? And number two, remember this is not part of this presentation, but we do have what is called a pain medication ladder.
Mhm.
I don't think opioids
They're there. They
being,
are. They're the last tier. Yes.
they're not fast.
They're not first line. Yeah.
It's something when somebody comes with a headache and you say, let me start with morphine.
Mm.
Let me start with the fentanyl, or even the commonest one, tramadol.
Mm-hmm.
Would that be your go-to? So, Brian, my response to this is we need to find out what type of acute headache this is before we think about how we are going to manage it appropriately.
Mm.
Use your pain medication ladder. It always helps.
Yeah. And I think we've all met patients who are screaming, saying that they're in severe pain, severe pain. Not that I'm dismissing it, but you give them IV paracetamol and they're fine. So yeah, there's a reason why there's a pain management ladder. So just follow it. There's also a pain management algorithm we have, which yes, severe pain can start with a week opioids, but it's to your discretion. Yeah. And then also like we've just said earlier, triaging your patient, especially reviewing after you've done an intervention, it gives you very good clinical insight as to what could be going on with the patient.